Aaron, and thank you all of you for joining. As Aaron mentioned, this is part 2 of our survivorship talks. The last time we spoke, we addressed the immediate toxicities of the drugs and the impact on our physiology. And today we will talk about the long-term impact of the cancer treatment and how do we deal with the survivorship issues. And who is a survivor? We'll describe that to you. And then at the end of the talk, hopefully, we'll have a better understanding of where we stand, what we are supposed to do, and there'll be some call to action. So let me share the screen with you. Okay, can everybody see that?
Yes, you're all good.
Okay, so who is a survivor? The definition that has been put out by the National Institute of Health, NIH, is that anybody who has cancer at the time today or has had cancer and is either cured or is living with cancer. So pretty much every cancer patient can be considered to be a survivor for that matter from what we are talking about today. Just some figures to share with you. Estimated about 2 million people will be diagnosed with cancer in the United States this year. And about 611,000 are expected to die with the disease. And that is from the American Cancer Society's figures, about 1,680 people in the nation die from the cancer. And to us, the figure that is more important today is the survivor number. So currently, not currently, but in January 2022, which is almost 2 years ago, there were 18.1 million survivors in the country. And that number is expected to increase to 26 million by 2040. So in another 15 years, the survivor number is going to go up to 26 million. Let's see if I can just move. There we go. So the survivor number is increasing due to some obvious and not so obvious reasons. One, obviously, is that the rate of cancer is increasing. Not necessarily the incidence, but the rate. And that is because we are living longer. Most of the cancers occur in older age, although some occur in very young age, like in children, cancers of the childhood. And then the curve drops off, and there's a little bit of a bump in the middle age, like 30s, 40s, 50s, when you get to see lymphomas and Hodgkin disease and stuff like that. And then other types of cancer, what we refer to as solid cancers, usually occur at a later age. We are living longer, and that means that we are being exposed to whatever causes cancer up in the air, in the food we eat, and the environment we live in, and the damage that occurs to our DNA. Longer we live, the more the chances are that something will go wrong with that DNA and cancer cells will appear and start to divide. Also, I think the environment is not as clean and safe as it used to be. We are exposed to far more chemicals in the food products, in the air and the water than we used to have, a long time ago. So definitely the environmental toxins are greater. We are living longer. Also, we are finding cancer much earlier. The technology has become sophisticated that we can diagnose cancer from very early on. And of course, the treatments have gotten much better. So people are living with cancer for decades now. When I joined the treatment, as I mentioned in my last talk, metastatic cancer, stage 4 cancer, the best you could get out of it was 3 to 4 years. And now I think it is quite common to meet people and see people in the clinic who are 10, 15 years out from their disease. I am a cancer survivor. I had blood cancer diagnosed in 2011. And here I am 13 years later, 3 relapses, 3 remissions. The treatments are available, they're working, and I can continue to live fairly normal life. And so I'm, in this kind of a blood cancer, when I was treating this type of a blood cancer, nobody made it beyond 3 years. So that is another factor why the survivorship number is increasing. Most of the people with cancer actually do become free of cancer. We do cure cancer. I mean, that the feeling that cancer is not curable is incorrect. Many people do get cured from cancer. And as the slide shows, 15% at least, and some of the studies have shown, have been cancer-free for more than 20 years. So people who have lived long after the cancer and cancer treatments can suffer some long-term delayed consequences, which can impact their life and lifestyle. We'll talk about that. Majority of the survivors actually do very well. They have no long-term side effects, and they can return back to life, and as if nothing ever happened after many, many years. But some do, and those are the ones we will be talking about today. And because we are talking about long-term can be not only months, but years or even decades after the cancer treatment. Some of the impact of the treatment may show up decades later. The issues that develop could be very mild, or they can be much more severe and debilitating. Some side effects are temporary, meaning that they'll show up and they'll go away, but some may not and may permanently impact our lifestyle. So these are just a listing of some of the physical effects that one can expect from cancer and cancer treatment over a long period of time. Definitely pain is an issue, either physical pain or neuropathic pain. Physical pain meaning injury to the bone, pressure on a nerve, and so forth, whereas the neuropathic pain will be often due to the toxicity from the drugs that we use to treat cancer. Some of them are neurotoxic, and they damage the nerve ending, so you get this burning pain and numbness and so forth in the fingers and the feet. And that can be long-standing and can be very, very annoying and even impact your daily life. Fatigue is very common, although usually it is a relatively early on and short-lived. It should not go on for years and years. Same thing for lack of stamina, loss of muscle mass, urinary and bowel problems, if long-lasting, are usually resulting from radiation therapy. Chemotherapy does not cause long-term urinary and bladder problems. Surgery does, for example, if you've had prostate cancer surgery or surgery related to bladder and so forth. So there may be some long-term effects of those. Sleep issues are again usually temporary. Lymphedema is a common problem. It used to be much more so than it is now with management of breast cancer. In the old days, we did far more aggressive surgery under the armpit to remove the lymph glands. Today, we can do selective resection or removal of one lymph gland to see if the tumor has spread there or not. And I'm sure that going forward, we may not have to even do that with the technologies that are emerging to tell us if the cancer has spread beyond the breast tissue. So lymphedema used to be, although some patients still have that long-term side effect when the arm becomes very swollen and the tissues become hard because of the fluid cannot easily return from the arm. We have issues which are due to hormones, either due to the treatment or due to the cancer treatment or to the treatment of the cancer. And that is a premature menopause, which brings in all kind of hormonal changes, changes in the skeleton, calcium, and skin, and so forth. We have cognitive deficits. We have all heard of chemotherapy fog, that it affects the brain, and sometimes it can linger on for a while. Definitely, there's issues of infertility, particularly those who receive chemotherapy at a young age, sexual dysfunction, dry mouth and dry skin. Dry mouth is almost always the result of radiation therapy for head and neck cancers because the radiation damages the salivary glands, which do not produce enough saliva, so the mouth is dry, which makes it difficult to eat and chew and so forth. And neuropathy we mentioned already. At least 50% of the survivors have been reported to have some sort of a long-term side effects, either from the cancer or the cancer treatments. However, we do know that each one of us is a very different biological being. How we react to certain drugs, how we react to the treatment varies from person to person. So some people will have far more long-term lingering things, and the others may not have that. So it's very variable, and each person has to be evaluated based on their own, not only their own physiology, their own genetics, but also what other health issues they have, what other drugs they are taking, and so forth. So the impact of these things is very personalized, and the physician has to make the assessment knowing the history of that individual. It also depends what kind of treatment we had in the past. As I mentioned, radiation will often lead to skin changes, darkening of the skin, dryness of the mouth. If the radiation is then given to the pelvic area, one can get long-term effects on the rectum, causing frequent bowel motions, diarrhea, cramping, bladder shrinks so that the one has to pee very often, and so forth. And so radiation causes long-term lingering side effects, and they are fairly permanent. And we know certain chemotherapy drugs have toxicity on the heart and on the kidney and on the liver. So doctors do monitor the heart condition and the kidney and the liver functions while they are giving the chemotherapy. But sometimes these things will creep up slowly. And then if somebody already has some sort of a heart condition, then on top of that, if they've received a drug that can be a cardiotoxic, then one can expect to have more issues with the heart. So these are, again, depending on what type of cancer and what kind of a treatment. Psychosocial issues are very, very important. I mean, even though, as I mentioned, many, many cancer patients are actually cured today, but the impact that it leaves on our psyche and on our that is significant. The fear that the cancer may come back is very real. And I think that the physicians need to empathize with that, because just because the patient is putting up and carrying on does not mean that they are not fearful of the cancer coming back again. So that is an important issue that we, the care providers, have to keep in mind for our patients. Having had cancer can also have positive impact on one's personality. You learn to have dealt with a significant foe and came out. You learn gratitude for all that was done for you from your family, from your care providers, and the medical team. You appreciate life much more because you've been touched by this serious disease. And so it again depends on how you view life. If you're a pessimist or an optimist, but definitely having had an episode of such a severe illness, and coming out on the other end sort of makes you feel, makes you appreciate life much better. Of course, distress and fear, as I mentioned already, continues on. And in some of the studies, it has shown that up to 20% of the people actually will have significant fear and depression caused by their previous illness, which will go on, they will go on to live with that, which is quite distressing. Actually, PTSD has been reported in about 20% of the patients who have had cancers and are now survivors. Of course, there are issues with families, there are issues with insurance, life insurance, and so forth, which are long-term effect. There could be impact on the employment because some of the employers may not want to hire somebody who has a history of cancer because it will be considered to be a costly affair for the employer. So all those issues are something that we need to be aware of. And many of the healthcare teams, the oncologists and their have social workers who pay attention to these things and look into it and see what can they do to mitigate. For example, writing a letter to the employer, standing up for you to make sure that you have insurance coverage, making sure that you are not discriminated at the workplace and so forth. We have to worry about having cancer again because patients who have had cancer once are at risk of developing another cancer. Whatever made them have the cancer for the first time, whether it was their gene, whether it was the DNA, whether it was the environment, whatever it was that make them vulnerable the first time around can also make them vulnerable for having another cancer. So we consider this group as a high-risk group, and they need to be, this particular issue needs to be addressed by the team who is providing the supportive care for the survivors. So what is it that we are doing in terms of the oncology community to address this issue of survivorship? Actually, it has become a topic which is now given significant space in the textbooks, in the annual conferences that we attend and so forth, because as the number is increasing, we need to address the increasing need of managing the cancer survivors. And all these areas that I mentioned need to be kept in mind. So here's one example. One is something called the Live Strong Foundation. And this is something that was developed just to manage or help cancer survivors. So this group got together and they came up with this kind of a plan in which they will address psychosocial issues, have a treatment summary, set up how to screen for new cancers, how to do surveillance for the previous cancer to make sure that it's not coming back, and if it comes back, how to address it and pick it up very early on, how to develop a care plan which can work with the primary care physician, your family physician, your internist, and the oncologist. So provide a coordinated care between various specialties so that you can be looked after and all your issues are addressed. Health promotion, health education, and of course, symptom management. If there are long-term symptoms like neuropathy and so forth, and pain, they need to be addressed on an ongoing fashion. So there is now effort on the oncology societies, like I belong to the American Society of Clinical Oncology, and other cancer-related specialty societies, surgeons, radiation therapists, and so forth. And they are working closely with the general medical community, like the internal medicine people, family physicians, and so forth, and developing a coordinated approach. And to that effect, they have come out with written guidelines for the primary doctors as to what to look for uh, and how to screen for any recurrence of cancer, how to address the ongoing long-term side effects in cooperation and collaboration with the oncology team. Oncology team needs to move on and see new patients and so forth. So as the number is rising, we cannot produce too many oncologists. So the pressure on the oncologists is increasing to see more and more patients, the new patients, those who are undergoing chemotherapy and treatments, and then, of course, the large increasing number of survivors. And, there isn't enough hours in the day, and particularly in today's corporate medicine, no more than 15 minutes is allowed to see a patient. It's very difficult for them to cater to all those categories of cancer patients. So it is very important that the specialty groups work with the primary groups, such as primary care physicians and so forth, and share with them the tools as to what to look for, when to look for, how often to do certain tests, and what kind of a test, and share the history of the treatment with each other so that the primary care doctor know what kind of drugs were used and what those drugs can do and so forth. So a coordinated effort is very, very essential as we move forward and we are treating more cancer patients and they are living longer. We have to address the survivorship issues. One of these groups, called the NCCN, or the National Comprehensive Cancer Network, actually is a group of specialists who put out guidelines for the treatment of different types of cancers. And there are more than 100 different types of cancers. And for this particular purpose, for the survivorship, they actually gathered about 30 experts, pretty much from every large cancer hospital or institute in the country. So this committee has put together a document which addresses the survivorship of cancer patients. We also have similar, as I mentioned earlier, ASCO, the Society of Clinical Oncology, is also working very closely with the American College of Physicians, Academy of Family Physicians, and so forth, to develop and share these guidelines. This is the NCCN survivorship guidelines, and I have shared 2 PDF documents with Erin. And, you can put in the chat if you wish to receive them. She can send them to you. You can also look them up yourself, the National Comprehensive Cancer Network. If you Google this, you will come to this website, and you will have to go through a couple of pages of searching, and you will have guidelines for physicians, which you don't want. They're technical and medical, but they also have guidelines for patients written in the lay language, which address issues that the public should know and what they need to do. And these documents will be very helpful to those who are going through this particular issue as to how to manage it themselves, how to bring it out to their primary care physicians, and be more educated about these things. So this is where I put down, the website is nccn.org/patient guidelines. If you go to this particular page, they are free, and they're freely available, and they are put together by some of the experts in the field, all from all across United States. So this is one of those documents, is survivorship care for cancer-related late and long-term effects. Most of the things that we talked about today are listed here, and it also offers some of the management. How do you deal with neuropathy? How do you deal with dry mouth? How do you deal with, issues with the bowel and the bladder, the radiation effects, and so forth. So I think that this will be very useful for those who are interested in learning about it. These are PDF documents which can be easily downloaded and read on the computer or your iPad, or you can print them out. This is another one, and this is called Survivorship Care for Healthy Living. Okay, the whole idea of treating cancer is to have you return, me as well, and you, to return back to as normal a life as we can. So I think it is very important that we look at these things and see if we can live as normal as we can. So here is a to-do list for all of us, the survivors of cancer. We should take charge. We should not sit back. We should educate ourselves and learn more about it so that we are educated. So when we have a conversation with our doctors, primary care doctors, we can tell them, hey, there are these survivorship guidelines and tools that are available now. And if you're not familiar with it, have your staff pull them up, and then, at the next visit, we can talk about it. Keep records when you move from one doctor to the other, particularly. Make a note, develop a small diary, and because things can, you can forget things, particularly for those who are long-term survivors. I'm now, into the 13th year, so I keep a little log. When did I start this treatment? When did I stop this treatment? What serious or minor issue happened here and there, so that I can look back at it, and if I'm with the different doctors or with my primary care physician, I can then share that information. So keep a log, develop a record of what's going on, not only of the treatment, how you feel, what kind of side effects you felt, what did you do, what worked and what didn't work. Also, very good practice is to write down a list of questions that you're going to ask your doctors when you go for a visit. Very often when we go to the visit, either the conversation goes into a different direction, or we feel inhibited and we don't want to ask the questions, or the doctor is in a rush because there's a shortage of time or whatever. Make a list of questions that you want to ask the doctor. And if all of them don't get answered, make them known to the doctor the next time when you go. So it makes your visit worthwhile, because you otherwise you're going to forget what to ask when you get there. We already talked about asking your primary care doctors to look up the literature, go to the NCCN guidelines page, and they have their survivorship tools for the physicians. What I have showed you was the one for the patients, but the same organization puts out a very detailed list of what to do for each type of side effects, long-term side effects, and how to treat and manage that. And then from a psychosocial point of view, we just have to learn to live the life to its fullest. We can be depressed and worry about the cancer coming back, or we can go out and sun is shining and we're going to do our meditation in the morning, and we're going to go to the gym or go for a walk and so forth. So we have to learn to return back to the life that is enjoyable to the degree possible. I mean, there will be some side effects which may prevent us from doing certain things, but there's a whole lot more that we can do. So I think a positive attitude towards life and making the best out of each day that we are in this survivorship mode is probably the best thing to do. And again, as these documents will show and will actually tell you, to eat well, sleep well, continue to maintain some degree of exercise. Even walking is good. Go to the nature, be by the riverside, go to the park and so forth, where you feel refreshed, because all these things have a positive impact on your immune system. And then at the end of the day, healthier immune system means less likely that the cancer will come back, and if it comes back, it will be much easily manageable. Have faith that the new treatments will work. I mean, I give credit to my medical team and credit to God Almighty that, 11 years ago, when I started the treatment, I wasn't sure that I will be alive and well 13 years later. And because the new drugs continue to come up, one is more effective than the other. So, keep that hope alive that if by any chance the cancer comes back, there will be newer options and newer treatments available, which may be more effective and less toxic than we have had in the past. Consider enrolling in clinical trials. Clinical trials is the only way in which we scientifically show that a particular treatment works or not. And there are many, many trials that are looking at to enroll survivors, because they're looking at what is it that they can find out before the cancer comes back. With the new DNA technologies, we can now do blood tests which can pick out a tiny, tiny, tiny little piece of the DNA that is shed by a cancer cell. And from there, we can say whether or not cancer cells are coming back or not. So